Okay, excuse me, good morning everyone. My name is Mark Menser. I am the chair for the Symposium and want to welcome you this morning to this breakfast symposia. We have Dr. Lang and Dr. Monzon who's going to present to us about the newest oncologic emergencies.
Great, so good morning everybody. Thanks for coming out this morning. My name is Eddy Lang. I'm the conference chair and the department head here in Calgary. And you're in for a treat this morning. I think we're going to have a great talk ready for you. We are going to talk about the newest oncological emergency. And as some of you, I think, are witnessing, the landscape of cancer treatment is changing. It's for many cancers, it's becoming more of a chronic disease. And you're going to hear about an important new class of therapies that are landing patients in our emergency department with the need for some astute assessment and some maybe non-traditional management approaches. So these immune checkpoint inhibitors are the focus of our presentation today. Got to do my disclosures. I do work with industry, and the companies that I work with are noted here: Novo Nordisk, Pfizer, and BMS Pfizer. Since 2013, however, I do not accept any honoraria personally and direct everything either to to our Calgary Health Trust Research Fund to support trainees, or the Emergency Medicine Advancement Fund here at CAEP, which is so important to launching careers in our specialty. And that's more detail there, and we're going to mitigate the potential bias by, of course, going through the usual routine of vetting the slides through our scientific committee and getting accreditation and approval. So it's my pleasure to introduce to you Dr. Jose Monzon. He's an oncologist here in the city of Calgary. Dr. Monzon completed his postgraduate medical oncology residency training at UBC and translational fellowship at the Canadian Cancer Trials Group. Also has a PhD focusing on melanoma genetics at the U of T. And his current research interests include pharmacogenetics and clinical trials in cutaneous and gastrointestinal malignancies. Just before we welcome him with a round of applause, just want to say a couple of things. Dr. Monzon was kind enough to address our clinical group here in Calgary at Ground Round several months ago, and that was really, really well received. And lastly, we don't have a handout for you, but I was very lucky to work with a student to create a review article that Dr. Monzon helped us with as well. And if you were to Google 3 words, Cureus, C-U-R-E-U-S, so not spelt the normal way, but C-U-R-E-U-S, that's the journal, Simmons, S-I-M-M-O-N-S, and then my last name, Lang, you'll get a full text free access article with some great tables and graphics that helps to provide an overview of this topic. So without any further ado, please join me in welcoming Dr. Monzon to our morning symposium.
Thanks, Dr. Lang, for the nice introduction. And I'd like to thank the organizers for letting me speak on this very important topic, especially since things are evolving so quickly in cancer treatments. And you know, although I treat melanoma and gastrointestinal malignancies, these drugs that I'm going to be talking about are actually being applied to a whole slew of different cancers, and even the more popular ones. So they are definitely going to be you're going to be seeing patients that are affected by these drugs and dealing with the adverse events that we see with these treatments. So I'll first start off with my financial disclosures. Obviously, I have advisory boards and speaker bureau honoraria through BMS and Merck, and also grants through Merck. I have consulting fees as well through a variety of pharma. And then no patents, and I had a travel educational grant through Amgen. These are my other disclosures. And then in terms of mitigating potential bias, I won't be recommending certain these new immunotherapy drugs. I won't be recommending them in terms of treatments, because we're here to just talk about how we manage their potential side effects. And all of this talk is purely for educational purposes. So I like to start off with a question usually, and I think we're a small enough crowd that we can actually vote by a show of hands. So this is a bit of a rhetorical question. So who here thinks that cancer is contagious? Just by a show of hands. Anyone? Any takers? Have very few takers. So I have another hypothetical scenario. Let's say we had some tumors, tumor cell lines growing in a Petri dish, and we injected it into a healthy individual. Do you think that it would grow or not? Again, another show of hands. Any takers? One, very rare, a couple down at that table. And then, would it matter if they were healthy versus a cancer patient if we injected these cancer cells or cancer cell lines into a healthy patient versus a cancer patient? You know, I said this was a hypothetical scenario. It's actually not a hypothetical scenario. They've actually done this experiment. It was published in Science in 1957. So what you can see here is that these are the cell lines. I'm going to focus on the left here, I don't know. But on the left column is the name of the cell lines. And then you can see that in cancer patients, when they injected them, they stayed viable, these tumors, for over 2 months in some patients, 77 days, 57 days, 60 days in the cancer patients. But then in these normal volunteers, they actually only lived a shorter period, no more than 2 weeks in some individuals. And by normal volunteers, these were actually inmates at their local jail. And this was, like I said, in the 1950s. So I have another question for you. If you had an actual tumor, could you actually transplant that from a cancer patient to a healthy patient? By show of hands, what do people think now that I've presented this cell line data? Yeah, well, the vast majority of people should now probably put their hands up, because again, there's been case reports of this happening. So the one on the bottom was published in the New England Journal of Medicine not too far ago, or not too long ago, 1996. And it was a surgeon that was cutting out a patient's sarcoma. And unfortunately, while he was cutting this out, he nicked his hand and cut through the glove. And a few months later, he had a mass there that was growing, causing him pain and discomfort. And they essentially biopsied this mass. They tracked down the previous tumor, and they actually did genetic analysis, and it was identical to the previous tumor from this other patient. So you have a healthy host that unfortunately got this iatrogenic introduction of these cancer cells that were foreign to him, and the cancer cells actually grew. And then on the top case, there's another interesting case report of a mother that wanted to help out her daughter who was dying of metastatic melanoma. And these scientists at NIH actually took some of the tumor from the daughter and transplanted it into the rectus abdominis muscle of the mother in hopes of generating antibodies or an immune response, and then ultimately harvesting that immunogenic sera and putting it back into the daughter in hopes of helping her treat her cancer. Ultimately, a month after the transplant of that melanoma tumor into the mother, a month later, the mother was having so much pain that they went in and cut out the tumor, and there were viable cancer cells there and cancer tumor. And then literally, probably around 10 months, as far as my recollection goes from this case report, both the daughter died of metastatic disease and the mother was diagnosed with metastatic melanoma. And so again, it speaks to the fact that we have this sort of notion that our immune system can actually take care of fighting malignancy if we were ever exposed to a foreign cancer. But in these scenarios, for whatever reason, either the host was deficient in terms of their immune response, or the cancer found ways around the host's immune response, are the likely scenarios as to why these cancers were able to thrive in these unique or essentially different patients. So although I'm going to be specifically using melanoma as an example, as I said, these drugs are being applied to a whole slew of different cancer patients and also different cancer types. But I'm going to be using melanoma as an example, and I'm also going to be using melanoma as an example because I want to demonstrate to you the magnitude of benefit that we're seeing with these patients. So melanoma is an immune responsive cancer. We oftentimes see spontaneous regression, or not often, but we have case reports of patients where they develop spontaneous regressions, and we don't know, but we think that this is an immune phenomenon. There's a higher incidence of melanoma in immune-compromised or immune-suppressed patients. When you excise a melanoma and cut into that tumor, you can actually see tumor-infiltrating lymphocytes, suggesting that the tumor is eliciting an immune response and that the immune system is acting towards that cancer. Melanoma exhibits cellular properties that can be explained by immune selection. And lastly, we've seen dramatic clinical responses that have been demonstrated with immunotherapies, and I'm going to be getting into that. Some of the theories as to why melanoma is so immunogenic is because it harbors one of the highest mutation rates of all the cancers. And we think that this is all UV, or in part UV and sun damage mediated. And when you have lots of mutations within your tumor, in the DNA or the instructions of your tumor, essentially that translates into proteins that can be seen as neoantigens or foreign antigens to your immune system, so your immune system can elicit a response to it. Now, in terms of demonstrating the magnitude of benefit that we're seeing with these immunotherapy drugs, I need to talk about the past treatments that we've used. So in the past, probably before 2012, the treatment for melanoma was dismal. The 1-year survival was only 1 in 4, so keep that in mind, 25.5%. And the 2-year survival was less than that. That was probably only about 5 to 10% at most. So this brings us to these immune therapy checkpoint inhibitors. I'm going to just quickly go over what this is, what this cartoon represents. But essentially on the left is that in the context of an anti-cancer immune response, you actually want your immune system to be turned on. Our bodies have normal mechanisms to turn off our immune system because in the context of chronic inflammation or energy, you actually don't want your immune system to be always on. And so sometimes the tumor hijacks these mechanisms to turn off our immune system so that our immune system doesn't act on the cancer. So on the left here, what you see is a T cell to be activated towards an antigen. It needs your MHC class molecule to present an antigen to the T cell receptor. It's sufficient to turn on your T cell, but it's not, it's necessary but not sufficient to turn on your T cell. You need another interaction. You need this B7 co-stimulatory molecule to interact with CD28. When you have these two things happen, your T cells are activated. Now the thing is that CTLA-4 is expressed on the T cell, and it competitively interacts with B7 and ultimately outcompetes CD28. And when CTLA-4 interacts with B7, it turns off your T cell. As I told you, you don't want your immune system to be turned off in the context of an anti-cancer response. And so drugs have been developed to bind to CTLA-4 and inhibit this stop mechanism on our T cells. Similarly, there's another mechanism that we use to turn off our immune system. is the expression of PD-L1 and its interaction with PD-1 on the T cell. So tumors themselves have hijacked this mechanism, and they express PD-L1 on its cell surface and ultimately interact with the PD-1 receptor, turning off our T cells. Again, we don't want to turn off our T cells in the context of an anti-cancer response, and so drugs have been developed to not only bind the PD-L1 ligand, but then also the receptor. So there's drugs that have been developed, these antibodies that I represent in the bottom right-hand corner here, have been developed to both the receptor and the ligand. And I'm going to talk about these drugs now. So this is one of the examples that I mentioned. This is a combined immunotherapy regimen of nivolumab and ipilimumab of monotherapy in untreated melanoma. And you'll notice a lot of these immunotherapy trials have been published in the New England Journal of Medicine. Again, it speaks to the magnitude of benefit and improvement we've been seeing in cancer treatments. But this demonstrates the magnitude. So first-line nivolumab and ipilimumab improved overall survival versus ipilimumab. So each of these lines represent treatment, and these are the survival curves. I got a laser here. But essentially the bottom line is single-agent ipilimumab, the previous standard, and then the middle line is nivolumab, which is one of the experimental arms, and then the nivolumab-ipilimumab combination was the top line in terms of survival. And so nivolumab and ipilimumab and nivolumab alone were superior to ipilimumab by itself in terms of survival. Unfortunately, we don't have the data in terms of whether the combination treatment of nivo and ipi were superior to nivo alone, but it was definitely superior to the ipilimumab. And then in terms of this magnitude of benefit that I wanted to demonstrate to everyone is that the 3-year overall survival in the combination arm was approaching 60%. And as I told you, previously to 2012, the 1-year survival was 25%. So that's a huge magnitude of benefit for our stage 4 melanoma patients. Now, the other thing is that I want to point out is the plateau in these survival curves. Now, a lot of these treatments were only given for no more than 2 years. So once you elicit an immune response and your immune system is acting towards the cancer, some of these patients have durable responses off of treatment. And although I'm not showing this data, it all started with this drug called ipilimumab. We have data out 10 years where people are alive. The same proportion of people that are alive at 3 years are alive at 10 years. Are we going to see the same plateau in the ipilimumab and nivolumab combination or the nivolumab alone arm in terms of durable responses at 10 years? I certainly hope so. Some people are even throwing out the cure word for stage 4 melanoma, which is unheard of. But it's very exciting times, especially for melanoma and for cancer treaters in general. So what does this mean? You know, melanoma is fairly rare cancer, but as I told you in the New England Journal of Medicine, these were all published last year. But just recently, in 2018, there's been new indications for immunotherapy in lung cancer, which is one of the third most common cancers, and then also in renal cell carcinoma. And so it again tells you how broadly applicable these treatments are going to become. And this immunotherapy spectrum of activity essentially shows you how many different cancer types these immunotherapies are going to be applied to. And not only that is that we're testing these in the metastatic setting, but oftentimes in the adjuvant and neoadjuvant setting, these drugs are going to be coming. So again, it's important for us to all understand their mechanism of action and how to deal with the potential side effects associated with them. So here are some of the unique characteristics associated with immunotherapy. So first is what I've already mentioned, is that the responses can be durable. And again, I'm using melanoma as an example because this is my field. So each of these, this is what we call a swimmer's plot. Each of these bars represent a patient. And it basically has on the x-axis time. And so what you can see here is that these red dots represent the time of first response. So more often than not, patients have a quick response to the treatment, usually within the first 6 weeks, and usually within the first 3 months of treatment. The other thing I wanted to point out is that, and I'm not sure whether you can see this or not, is that some patients actually stop treatment. That's what these yellow bars mean. And if you stop treatment, there are some patients that ultimately develop a response despite stopping treatment. So they have a toxicity, and for whatever reason, it's not tolerable, and they stop the treatment. The drugs are usually in people's system, and we think for months at a time, and potentially you can still develop a response off treatment. Not only that, is that some of these patients can have delayed responses depicted by the arrows, the red dots farther along. And then lastly, these yellow arrows at the end of each of these lines represent patients that have an ongoing response to treatment. And so you can see that the responses can be quite durable. Not only that, is that people that develop a complete response, and this is what I mean by the magnitude of benefit being remarkable. You know, people that develop a complete response, and the definition of that is essentially that they have so much shrinkage of the disease that it's no longer visible on a scan, essentially. So if you are one of these lucky people that develop a complete response, your chance of living 3 years is almost 97%. So again, it tells us how robust an immune response to cancer can be and how practice-changing these drugs are. Now, this is an interesting characteristic of immunotherapy. You can get unique response kinetics, and what I mean by that is you can get either pseudoprogression, and I also talked about late responses. But this is what we call a spider plot, and again, each of these lines represent a patient's response to treatment. If the line goes above the 0 mark, it means that their cancer is growing, but then if it drops below the 0 mark, it means their cancers are shrinking. And the one person or patient that I want people to focus on is this one that essentially goes up initially. Let's try this one. There we go. This one that goes up initially and then subsequently shrinks. Same thing on this side. I'll show people on this side is that when you see this go up above 0 and then it drops subsequently, essentially that means that people's tumors are growing, or at least it looks like that on the scan, and then subsequently shrinking. And I'm going to give an example of that as well in terms of a clinical example. So here's a patient that we treated with ipilimumab, which is a CTLA-4 inhibitor. And essentially they got treatment at screening. By week 12, the disease looked like it was growing and out of control. So, and this was demonstrated on the CT scan. Now in a classical chemotherapy, not immunotherapy, but a chemotherapy clinical trial, or in general, we would stop treatment and abandon treatment, and if we had an alternative treatment, we'd try and switch patients to a different treatment. But interestingly enough, this patient had no other alternatives, but because it was deemed that he had progression of his disease, they stopped all treatment and he was sent to the palliative ward. Subsequently, at week 16, it demonstrated that he was responding to treatment. And then by week 96, he had developed a complete response to treatment. And so again, it tells us that one, pseudoprogression is a possibility, and that potentially we shouldn't hold the treatment, and it can sometimes be difficult to determine how long to keep patients on treatment. But at the same time, you know, again, it speaks to how powerful our immune system can be acting on these cancers. So now this brings us to the most relevant part for you guys, the emergency physicians and emergency department team in regards to dealing with these immune-related adverse events. It requires vigilance and early recognition and early intervention. And also, I can't stress enough, a multidisciplinary team to deal with. So in regards to immune-related adverse events with checkpoint inhibition, In terms of the class of agents, CTLA-4 inhibition or PD-1, PD-L1 inhibition, you can see that as a class of drugs, PD-1 inhibitors are typically better, PD-1 and PD-L1 inhibitors are typically better tolerated compared to CTLA-4 inhibitors. The other thing I want to just point out is that grade 3-4 toxicity listed here is quite rare as single agents with PD-L1 or PD-1 inhibition. These are very well tolerated drugs, and by the way, grade 3-4 toxicity is the level of toxicity that can potentially hospitalize a patient or requires hospital intervention such as intravenous fluids or supports. And so you can see that the grade 3-4 toxicity for these agents are quite low. Now, with ipilimumab, it is slightly higher, but still reasonably well tolerated. Now, when you get into the combination immunotherapy drugs like ipilimumab and nivolumab, although I don't have a slide on that, definitely the grade 3-4 toxicity increases. The grade 3-4 toxicity in general for ipilimumab and nivolumab approaches 60%. So it is quite a bit higher. And as I said, there's more coming indications for combination immunotherapy. So again, you're going to be seeing more and more patients in your emergency departments in regards to these adverse events. And you can see that there's a variety of adverse events: rash, pruritus, diarrhea, fatigue, pneumonitis, headaches, asthenia, dyspnea, etc. And again, the ones for you guys in terms of what you may see are the skin toxicities, the colitis, the hepatitis. We do see irreversible endocrinopathies, and I'm going to get into some of these cases. There's very rare neurotoxicities. There's, for instance, reports of myasthenia gravis associated with this, and then also other neurological disorders. Pneumonitis, we've also seen go to the emergency department, and then nephrotoxicity. And so it's important to be vigilant whenever we're screening our patients in clinic. We're always asking about the symptoms and trying to discern whether it represents disease progression or alternatively side effects associated with these drugs. And so it's very important to realize that you can essentially get any autoimmune disease associated with these drugs. Some are more common and others are more rare, obviously. So here's my first case. This is a 43-year-old woman with a history of cutaneous melanoma, resected 5 years previously, and then presented with metastases to the bladder, urethra, lungs, perinephric mass, and she received a PD-1 inhibitor in August of 2012. She got it for the first 3 weeks. She actually had enlarged, the tumor of her urethra enlarged by 2 centimeters, making it difficult to void. And her renal function was stable, and her performance status was good by week 8. And then essentially by week 10, she saw a decrease in her urethral lesion, and a scan showed that she demonstrated almost a complete response. Now, we continued treatment for another 11 months, and then she was followed by our pharmacy team, and then for routine toxicity, and we routinely do this. We sort of give our patients the riot act in terms of what can potentially happen so that they know when to report certain symptoms so we can act on them quickly. And then by July of 2013, just under a year later, she developed a CT scan showing infiltrates and ground glass, and she was having a productive or non-productive cough and associated shortness of breath demonstrated by these scans. Essentially, the treatment or workup for this is that, we need to do an infectious workup, and then also because she's on immunotherapy, we put them on prednisone or high-dose steroids, intravenous steroids right away. And then on a long tapering course, it usually requires at least a minimum 6-week course of tapering of steroids, and eventually these infiltrates improved. The other thing about this is that what we have to realize is that sometimes these infiltrates can actually recur even after the taper. And I've had some patients go on 3 long tapers of over 6 weeks, and that patient is actually on a 5-month taper now that we're trying to get this pneumonitis to resolve. And just an anecdote, when we were first treating these patients with PD-1 inhibition, I did have a patient, for instance, go to the emergency. They told their emergency physician that they were on chemotherapy, although it was truly an immunotherapy. And the chest x-ray showed that they were in heart failure, and they were sent to the cardiology ward because they had a mild bump in their troponin. And then I realized that the patient didn't show up to their clinic visit 2 days later, and then I realized they were in hospital. And I talked to the cardiologist, and they said, you know what, despite our diuresis, the shortness of breath and oxygen requirements hasn't been getting better. I immediately took the patient over, and within 2 days of starting the IV high-dose steroids, it actually got better quite quickly. So the key for us is to, again, recognize that these things can happen. Early implementation by steroids, and also workup for other causes is very appropriate. So, working up for heart failure, pneumonia, and things like that, and cultures is very appropriate in patients that we just don't know exactly what's going on. But we have to keep that adverse events associated with immune therapy as a very possible etiology. So in terms of their management algorithms, and I can provide these, and also there's a lot of guidelines out there that are available, and we were thinking of even coming up with guidelines that we can post in our local emergency departments in terms of how to manage the pneumonitis, for instance. If it's grade 1, it's usually asymptomatic. If it's grade 2, it's mild to moderate new symptoms. We usually hold the treatment at that time. If you develop grade 3 or 4, which usually is severe symptoms that require hospitalization and oxygen supplementation, we have to discontinue their treatment. And then again, it requires high-dose IV steroids, usually the equivalent of 1 to 2 milligrams of prednisone daily. So the next case that I want to present is a case of hypophysitis. And this again was a 55-year-old gentleman with stage 4 melanoma who had progressed on targeted treatment, and he started another PD-1 inhibitor called nivolumab in 2017. And after 6 cycles, he presented with a severe headache, severe nausea, vomiting, and profound fatigue. And I didn't say this, but he also had low blood pressure, and he presented to the emergency department. You can see here that his cortisol is quite low at 80, and he also had some mild electrolyte abnormalities. Because of the low cortisol, we know that, again, we can develop irreversible endocrinopathies due to these immune therapies. We started him on 60 milligrams of prednisone daily, and the patient basically, oftentimes with the secondary adrenal insufficiency or the hypophysitis, people make a marked recovery. Literally within days, they feel better. And this MRI just represents what can happen. You get essentially inflammation of your pituitary gland, and essentially the immune system is attacking our hormone-producing glands like the pituitary, causing it to not produce the hormones we require. Unfortunately, these are typically irreversible. I've yet to have any patient have a reversible endocrinopathy. One of my colleagues did have one case of a reversible hypophysitis, but unfortunately I've yet to see that. I think it's extremely rare. I've seen also cases of hypo and hyperthyroidism. I've yet to have a case present to the emergency department that way, but usually we're checking these thyroid indices quite regularly. But having said that, these drugs are going to be used in community oncology clinics, and so I know that there's a lot of community emergency physician and department staff here, and eventually you'll be seeing hypo and hyperthyroidism presenting to your emergency department. Again, as I mentioned, you can get primary and secondary adrenal insufficiency. And interestingly, the reports of type 1 diabetes occurring with these drugs, where your immune system attacks your islet cells of your pancreas, causing type 1 diabetes, is reported at 1 in 2,000 to 1 in 10,000. But here in Calgary alone, we've already seen 3 cases, and one of my patients actually presented to the emergency department with DKA. And it's treated exactly the same way as you would typically treat a diabetic ketoacidosis. The next topic, adverse event that I want to talk to you about is colitis. And you'll see a general theme here that if it's grade 1 in nature, usually we treat supportively, usually with IV fluids and some type of adjunct medication, in this case Imodium, for instance. But once it becomes grade 2, 3, or 4, we have to hold treatment, and of course we do an infectious workup. I oftentimes get a C. diff, a culture stool and sensitivity. Sometimes when patients are hospitalized, we'll also require GI to be involved to do a scope. But essentially what it requires is high-dose steroids. I don't wait for the cultures to return before I start the high-dose steroids. Sometimes I do combine antibiotics with the high-dose steroids because there have been some rare reports of bowel perforation associated with this as well. And so, as I mentioned previously, the appropriate workup is to get have a broad differential, include the fact that it could be from this immune-related toxicities, and then implement high-dose steroids at that time, and also follow up with cultures, sometimes combining with antibiotics. There are often times where we'll get our GI colleagues involved as well. Now, in terms of the grade 3 and 4 colitis, in protracted cases where the steroids don't seem to help within 1 to 2 weeks, sometimes we're incorporating a different immunosuppressive drugs such as infliximab. And infliximab is a very expensive drug, but we do use it infrequently to control people's colitis. In the last essentially 5 years, I've used it probably about twice. Now, again, with these drugs coming to our healthcare system, it does, I just want to mention this, we have to be fiscally responsible, and although all of these drugs are coming, it does put a burden to our healthcare system. You can see that the prolongation in life, the magnitude of benefit is significant, but at the same time, we're going to need to balance trying to be fiscally responsible, dealing with these immune-related adverse events, and treating our patients to prolong their survival. So again, it's a challenge for our payer system in the future. Now, in terms of dermatological toxicities associated with immune checkpoint, you can get rash, pruritus, hypopigmentation, and vitiligo. The more rare ones that, again, that you guys might see, again, Stevens-Johnson syndrome, you might get someone with a bullous skin disorder, but these are quite rare, but, can happen, so it's just important to be aware about them. Vitiligo, interestingly, is a predictor of response. Vitiligo is what Michael Jackson said that he suffered from. Essentially, it's autoimmune disease where your immune system attacks the melanocytes. And so, interestingly enough, patients that do develop vitiligo are more likely to respond to immunotherapy in the context of melanoma, because melanoma is derived from the melanocytes. So, just to summarize, the keys to managing immune-related adverse events. Most immune-associated adverse events are manageable as long as they're recognized early, and treatment with high-dose corticosteroids is crucial. Typically for grade 3 or 4 or recurrent immune-related adverse events, a slow taper of corticosteroids over 4 weeks is required. Optimal management of immune-related adverse events should involve a multidisciplinary care team. So a lot of our gastrointestinal and rheumatological colleagues that are seeing some of the other adverse events are very interested in these. And again, I'm very pleased to present this information to the emergency department physicians so that you guys know how to manage the potential side effects. We should remain vigilant throughout and after treatment, and it's important to educate and encourage our patients to also monitor and report the symptoms of these immune-related adverse events as well. Now, the last slide is very complicated in terms of what it represents, but I just want to quickly go over it. Essentially, what I'm trying to denote here is that there's a lot of things that turn on and turn off our immune system. And there's a lot of pharmaceutical companies out there developing drugs to potentially enhance the anti-cancer immune response. And so these drugs are a part of our future now, and likely they're going to be combined with other checkpoint inhibitors, again, to improve our anti-cancer immune response. And so our knowledge of these pathways is very important, not only in terms of improving the care for our patients, but also improving how we manage these adverse events. And that's the end.
A fascinating this presentation, and you know, I don't know if things are different in Alberta, but we're certainly seeing some of these patients coming into our emergency department, especially at the Foothills Hospital, with complications. So do we have any questions? Yes. And I don't know if there's a floating mic, because the acoustics are a little bit challenging in here.
You mentioned that they still have that response, like they've got a sort of learned response, which allows them to have the prolonged survival time that you were talking about. The case of the pneumonitis that you mentioned, does that only happen whilst they're on therapy, or can they get that due to that prolonged immune response after they've stopped therapy?
Yeah, it's a great question. You know, it actually can occur off treatment, and it's a bit unpredictable about when it can happen. And so the thing is, although we say off treatment, interestingly, we've debated about this, about how quickly these drugs are metabolized out of our system. You know, the half-life is about 2 weeks, and sometimes longer for some of these drugs, and usually takes months, if they were to follow first-order kinetics in terms of metabolism, usually it would be removed from our system within a few months, but we actually aren't clear how long these drugs are in our system. So it can occur several months even off treatment. I've seen cases.
But the highest risk period is closer to treatment.
Yes, definitely. Okay.
Is that okay? Yeah. We're going to flip over to the other microphone.
Hi, I'm Mark Reardon from Ottawa. I just wanted to ask, with these dermatitis, they're really, really late onset. And are there any distinguishing features that are going to tell me that this is an immune adverse reaction type thing?
Unfortunately not, no. You know, we've biopsied some of our rashes that we see, and they essentially look like the typical diagnoses, that there's nothing new about them or different about them. You know,
so I don't really going to know.
Yes.
If it's just he's got a regular, just some sort of, you know, eruption of some sort, and
yes.
It might be anything. It could be an allergic reaction or something like that.
Correct, yeah. You know, unfortunately there isn't, and all I can really say is, oftentimes when I get called about a patient with rash, one of the first things I ask is, oh, you know, are you having any mouth wounds or sores in your mouth? I'm always worried about that. I have yet to see the Stephen Johnson that's reported in the literature, but I always ask about that. You know, also I ask whether there's any blistering or sloughing of the skin in any of the rash areas. Again, you know, because I deal with some of these patients over the phone, and it can be very difficult. You're absolutely right. But I think your thinking is correct in the sense that, yes, we should have a very broad differential, but if they're on immunotherapy, we should also make sure that we have an adverse event associated with immunotherapy at the top of our differential, because usually the rash, it does get better with just some topical steroids that we use. Actually, that's not true. I had one case where I've given oral steroids to help control the pruritus and rash.
I guess if they have have a previous history of psoriasis or some of
Yes.
these other things, then that would certainly make you think
Yes.
that way as well too. Yeah.
Yeah,
Thank you.
you're welcome.
And I think Dr. Charnow is standing up longer. Go ahead.
My name is Marco Chalin. I'm from Montreal. You mentioned fiscal responsibility. Can you give us an idea of the price tag for those new toys?
Yeah, so I'm not privy to the actual price, but I know for the PD-1 inhibitors, for a year's worth of treatment, I suspect it's over $100,000. So you're absolutely right, it's extremely costly. In my mind, I do think that they're worth it in terms of what I've seen for my patients. As I told you, I have patients now that are actually, the longest patient I have out now is 4 years. She was treated with 2 years with the ipilimumab and nivolumab combination. She got the full 2 years worth, and she was extremely young, and she's now been out 2 years off treatment without any signs of her cancer active. You know, as I told you, we're throwing the cure word out, and we never do that for stage 4 melanoma. Now, in terms of the magnitude of benefit for other cancers, it has been slightly less or less impressive compared to melanoma, but we're identifying unique subsets where, you know, we are seeing durable responses as well. And, you know, I think it will be very difficult to discern, you know, that's why we're always about targeted treatments in regards to which patient population should we be treating, and trying to choose who are the more likely people to respond and who are the people that are unlikely to respond. And you know, we're always looking for predictors that way so we can personalize their treatment and hopefully reduce how much waste in terms of the drugs we use.
So just to follow up that, Dr. Monzon, we usually use roughly $50,000 a year for as a quality perspective to justify dialysis. We do dialysis. Has there been a neutral government-sponsored health technology assessment to say whether these are cost-effective?
Absolutely. These drugs go through rigorous review, not only at the provincial level, but at the national level. And oftentimes there are quality of life and also life assessments in terms of their financial assessment. So they're not approved at a sort of center-based basis. This is a national approval. So,
Another question over here.
now just one, before I get to that, one last thing about this, and another important aspect of cost is the duration of treatment. So we don't know what's the optimal duration of treatment. Oftentimes these trials looked at patients that were treated for a year versus 2 years worth of treatment. But for instance, people that develop a complete response, I just showed you data to suggest that if you develop a complete response to treatment, your 3-year survival is approaching almost 96, 97%. So should we stop treatment in those that develop a complete response? And I've seen complete responses in people that have received only 3 months worth of treatment. We don't know what's the optimal duration, but there are studies looking at the duration of treatment so that we can minimize costs as well.
Great.
Sorry.
Over here.
That's okay. I wanted to know, with diabetes, do you recommend corticosteroids as well?
Yeah, so that's a good question. You know, one, we don't give steroids for the diabetes, in part because that can cause maybe the sugars to flare and be more difficult to manage. Having said that, I don't know what the answer is in regards to if we were to start steroids in a patient that developed the type 1 diabetes, would it be possibly reversible? And what I mean by that is because the immune system is attacking the pancreas, obviously causing the diabetes to develop. And by starting steroids and calming that immune response or immune adverse event, is it more likely that there will be recovery of the pancreatic islet cells? I don't have that answer. But for all the other ones, for instance, colitis, the pneumonitis, definitely steroids are warranted. Actually, for most things, if you're seeing them, more than likely steroids are warranted, other than for the diabetes.
So I thought we had a question here, but just to follow up on that, Dr. Monzon. So say 100 patients come in with pneumonitis who have recently or are currently on these drugs, and I appreciate the importance of early identification and early steroids, but can you distinguish between infectious and non-infectious, or are essentially all of these patients going to be getting both steroids and an antibiotic?
Yeah, unfortunately there's no distinguishing factors on a CT scan or blood work as of yet. Definitely I've had most of my patients that come in with the colitis or the pneumonitis, they're oftentimes on antibiotics as well. But more often than not, those cultures come back. Actually, I've seen a couple with C. diff concurrently with the ipilimumab, oddly enough. And so the flagyl is very appropriate in that setting.
And just sort of to frame this for us, do you think it's reasonable for an emergency physician to initiate high-dose steroids in a suspected IRAE without consulting the oncology team?
I think it's definitely reasonable if it's high on your suspicion. One of my colleagues often says a patient shouldn't pass away without a dose of high-dose steroids if we're trying to resuscitate them. But our colleagues are on call, and that's what I like about the system that we've implemented. There's always a lot of interest from our supporting teams, and so that's why these talks are so crucial. And so we have a 24-hour oncologist on call all the time, and they are very aware of the potential toxicities. And so it's very important that you communicate that with us. But at the same time, I can see that when these drugs become more available in the community, I can't see how high-dose steroids in a patient that's on immunotherapy, especially if they're in a dire situation, I think it would be reasonable to start it and then subsequently contact the oncologist the next day, sort of thing. But I think it's reasonable if you have access to them to call them, especially if you're worried about this.
But still, if you take an overall perspective, most patients are still largely being treated with the typical cytotoxic chemotherapeutic agents. So the question is, what's the likelihood, especially if we're in a smaller community, a regional center, that the oncologist on call or even the internist on call will be sufficiently aware of these drugs and their side effects to guide us on management?
Yeah, there's no doubt. Yes, that's why these talks and these discussions are so important. And so it's about getting the word out that these drugs are coming. They are going to become more common. And having said that, there's wonderful websites out there in terms of managing these toxicities. I wish I actually put up a slide on resources of where to go, but I can get them to you, Dr. Lang, and then maybe you can disseminate them. But there are definitely websites on how to manage these immune-related toxicities. But essentially, what it is early recognition and at least entertaining that it's possible as a diagnosis, and then consulting the supporting team, oncology team whenever available, and then always thinking about steroids in the back of your mind if you have it on your differential.
A couple of days ago we had a symposium on hemophilia, and one of the take-homes was that often these, because they're uncommon, the trouble they get into, they walk around with these cards that help raise our awareness about the potential side effects. Is that coming? Or?
Yeah, I think that's a great idea. Initially, one of our pharma sponsors actually had a medic alert type bracelet and actually had a number and a website as to where they could access the information. For some reason, it just it fall into the wayside, but I think that's a great idea. And same thing, I think you had mentioned previously at one of our previous talks, potentially getting up signage in the emergency department about how to
or an
deal
order
with.
set.
Yes, yeah.
Great. Any other questions from the audience? For the handouts? Okay, so what you'd have to do is you have to Google 3 words. The name of the journal is Cureus, C-U-R-E-U-S, so not the typical spelling of curious. And the two last names to throw in there are Simmons, as in Brett Simmons from the Rocky View. It's his son, Simmons, and then throw in my last name, Lang. If you put those three terms in Google, then your first hit is the full text access to that paper, and Brett created some really nice tables to help summarize the treatment and the features of some of these immune-related adverse events. Is that okay with everybody? Good. Well, this has been a fascinating discussion, and it's great to have a presentation really that's focusing on practical management of complications that we might see in the emergency department. I'd like to thank you, Dr. Monzon, for coming and being with us today.
Yeah, thank you, everyone.
All right. So again, thank you to Dr. Lang and Dr. Monzon. That was excellent and great discussion. Thank you for your questions.
Just one last thing. If it's also a really good time between now and the start of the plenary to just wander out and see some of the great posters that are being put up for today. So just a thought.